Yes. A good evening to one and all present here. We are starting sharp today, and I welcome all our participants as well as our esteemed speaker, Srikanth, Dr. Srikanth, who is very generous enough to accept our request and enabling us to learn from a scientist who is there in the middle of the things to talk about dengue. As we have already announced last week, today's topic is dengue, and Dr. Srikanth is talking on tackling dengue, a short overview and integrated vector control strategies. I would like to remind our respected speaker as well as our participants, this month we are focusing on this zoonotic diseases, especially since 3 sessions we are talking on Nipah, leptospirosis and dengue, because at least leptospirosis and dengue cases have been on the rise in my hospital, as well as Nipah was in the news for some time in Kerala. So we addressed all these current topics of interest for us to be aware. But beyond that, today I'm very happy to invite Dr. Srikanth Sri Rama. I will read a short bio, but I'm very happy that he's trained preventive health specialist like me. He also has an MD in community medicine. I'm very happy to see Dr. Srikanth taking this session. And he completed his MD community medicine from BIMS and RC Bengaluru. And he's an experienced education professional with 3 years of experience as an assistant professor, currently with a 6-month experience as a hospital administrator at PESI-MSR. The use of technology for public health system strengthening and systems approach to the elimination of public health threats are Dr. Sriram's passions. He currently is working on vector-borne disease burden in acute febrile illnesses and Kaisanur forest disease. As all of you have seen his affiliations, Dr. Srikanth is Scientist B, Medical Category, Unit of One Health, ICMR Vector Control Research Center, Indira Nagar, Puducherry. So I extend a warm welcome and sincere gratitude to Dr. Srikanth for accepting our request. So you can take over, Dr. Srikanth.
Okay, ma'am. Thank you. Thank you for that warm introduction and welcome. I hope all of you are able to hear me. I'm audible. So
yeah, you're audible, but if you can improve a little bit more, it will be perfect.
Okay. Yeah. So why don't I come a little closer to
Yes.
Yeah. So we will start today with talking about dengue, because when we speak of One Health diseases, we usually have multiple components of One Health, right? We say that human health, animal health, and environmental health are all interconnected. And dengue is one such One Health disease because the climate component is plays a huge factor in the propagation of the disease. We all know that we have a epidemiological triad where we say that there is a host, there is an agent, and the environment, and these three interact and they cause the disease. So here, under the environmental component, because of the changes in climate, the number of cases of dengue is continuously rising. And dengue is also a very dangerous disease. So we'll have a very short overview of what is dengue and uh, what we do from a laboratory aspect, how we are looking at it. And then we will have a short, a short discussion probably on integrated vector control strategies that we can use for control of dengue. Sorry. Yeah. So as we know, dengue is an arthropod-borne disease. So we call it as an arbovirus. That is an arthropod-borne virus, which is a single-stranded positive sense RNA virus, which falls under the family of Flaviviridae and the genus Flavivirus. It causes from anywhere between 100 to 400 million, that is 1 to 4 crore infections every year globally. And almost all the tropical countries of the world are endemic to this disease. There is an increasing number of the infected cases, even since 2020, which has made this a very serious viral disease after COVID-19. So countries such as Philippines, Vietnam, India, Colombia, and Brazil have reported the highest number of dengue infected cases. In Africa, it derives the word dengue comes from the word kiringapopo, which means sudden cramp-like seizures or fastidiousness, which is the Spanish root for the word, which means that these people don't want to move because it is associated with very painful moments and a lot of lethargy is associated with the disease. And we've been discussing or we've been seeing the disease for the last 250 plus years, right? In about 50 to 60 years ago, we have noticed that dengue as a virus had about four different serotypes, that is dengue 1, 2, 3, and 4, which caused the diseases. But then very recently, about 10 years ago, a fifth serotype was also identified, which was earlier thought to be sylvatic dengue, but then it was later on proved to be an entirely different serotype of dengue. So dengue virus is a small icosahedral enveloped virus. So it consists of 11 kilobytes of positive stranded RNA. So there is a structural part, there is a non-structural part. There are seven non-structural proteins. One of them, that is NS1, is very familiar to all of us in clinical practice because this is what we use for diagnosis of dengue in the clinical practice now, right? Coming to the geographic distribution, as I said, it has continuously been growing. And around the world, almost half of the world's population are at high risk of dengue. And coming to India, we have conducted a dengue zero survey, which showed that almost half of the Indian population has been exposed to dengue and has suffered from dengue. So this in itself would not be a very severe thing because in general, dengue, like most viral diseases, is a self-limiting viral disease that is, within 7 to 14 days of fever, and then it goes off. For the first occurrence of dengue, most commonly, this is what we see. But then it is the second occurrence of the disease that is more serious or more severe because there is something that we call as ADE. Okay. Antibody dependent enhancement that we see in dengue, that is the previous existing antibodies will increase the body's reaction to the disease, and therefore we see a more severe type of disease with worse outcomes. So as I said, in almost all the tropical countries, we see the disease. This has to do with the vector of the disease, which is Aedes albopictus, which is very active in these areas. And the tropical climate of these countries allows for the vector to grow. We shall discuss about the vector presently, right? And this is a heat map of the same, depending on the number of transmissions of dengue that we see. In India, as I said, we had 48.7% seroprevalence of dengue infection. That means almost half of the Indian population has been exposed to dengue. And the highest seroprevalence is seen in the southern regions, which is nearly 77%, and followed by the western and the northern regions. Most commonly, even in India, we see very high cases of dengue serotype 2. And then till 2023 September, we have seen a huge spike in the number of cases. So why this is important to us now is that dengue as a disease causes a lot of strain on the public health system, right? If you take just Karnataka or Uttar Pradesh, for example, 5,700 cases of fever, and at a time, if these are 5,700 cases of diagnosed diseases, right? And at a time, if they present to the public health system, then they will overburden the public health system, and we may not be able to provide adequate care to these patients. So, what are the different types of patterns and determinants of the disease, and why do we need to study them? Is because one, we need to know the disease surveillance right? So we need to know how the disease is progressing and what we need to do to be prepared for the disease. And then we need to do a risk assessment. That is, what are the changing trends in both the environmental side of it as well as in the ecological side of it, which is causing an increase in the dengue disease. The outbreak investigations, public health planning, but most importantly, the resource allocations. So, which areas require more intensive or higher amount of resources to be allocated to them because of dengue is a very, very important aspect of why we need to study the epidemiology of dengue. And then we also need to study it so that we can evaluate the interventions that are available. So, as I said, we would be these are the two major vectors of dengue in uh, India. One is Aedes aegypti, the other is Aedes albopictus. Now we also call them as we reclassified them as stegomia. So you would see reports of stegomia aegypti or stegomia albopictus, which is basically the same mosquito. Okay, these are day biting mosquitoes, which are diurnal. That is, they bite 2 hours after sunrise and 2 hours before sunset. Uh, in general, maybe around up to 9 to 10 o'clock in the morning, and then starting from 4 o'clock in the evening till sunset, these mosquitoes bite. And they're very active mosquitoes, but also they're very temperamental. That is, they're very fussy feeders, right? So they're very nervous. Even small movement somewhere nearby, they will just fly off. Okay. And this is a very, very dangerous thing because to complete the blood meal, this mosquito is going to bite multiple people because it is a very nervous feeder. If it sits and finishes feeding in one round, then it would only be infecting one person. But because it's a nervous feeder, it just flies off and it finds the next nearest person. This is why we usually see dengue cases in clusters. So if one person in a family has dengue, it is possible that there would be other people right around this person who would also have dengue because the mosquito that bit this person would have probably bitten other people around them to finish its blood meal. Coming to mosquitoes, another usual misconception that we have is that we do know that female mosquitoes bite and take a blood meal. Okay, but we usually assume that that is the only meal that the female consumes, which is not true. Female mosquitoes can survive on plant nectars as well as sugary substances or sugary liquids. But then to lay eggs, they require iron and proteins, which are only available in blood. Aedes mosquitoes specifically are anthropophilic and anthropophagic mosquitoes. That is, they usually prefer biting humans. But then when humans are not available, they will also bite animals that are easily available to them and take the blood meal. So there is also a component of animal health that comes into this. But then because we usually have enough humans that are easily accessible to these mosquitoes, they're always prefer feeding on humans. And these are very hardy mosquitoes in the sense that the eggs of these mosquitoes can survive for a long duration. They can even survive being frozen. They can even survive being dried. We all know that the mosquito bites humans, takes the blood, and then it goes to any collection of fresh water in and around the house. It sits there and it lays the eggs, right? So these eggs can dry off, the water can dry off, and the eggs will survive there. And even after 6 months, when there is enough water that comes in, the eggs can hatch, all right? So the entire life cycle of this mosquito is optimized for conditions that are prevalent in urban India. It is well adapted to human settlings. It knows ins and outs of our households. It prefers breeding around the houses, and it takes 7 to 10 days for an egg to hatch and become an adult. And once it becomes an adult, within 3 weeks, it has uh, mated, it has had a blood meal, and it would have laid a clutch of at least 100 to 300 eggs can be laid by one female mosquito. Coming to the transmission, in dengue, we have two transmission cycles. One is the extrinsic incubation period, one is the intrinsic incubation period. So once a mosquito feeds on somebody who has uh, dengue virus, they acquire this infection, and then within 8 to 12 days, the infection establishes in the mosquito's body and then gets secreted in the saliva. Then from day 10 to 14, when the mosquito bites healthy persons, it transmits the virus to them. And once the virus enters the human body, within 4 to 7 days, it starts showing symptoms. It grows to enough quantity to start showing symptoms. And then this viremia period will be there from day 3 to day 10, average of 5 days. But usually, what we see is by day 3 of fever, the viremic phase has ended, and only the post viral sequelae are present. So this extrinsic incubation period is a very important aspect of dengue that we usually don't consider, because although we say 8 to 12 days is the extrinsic incubation period, but given proper uh, climatic factors, given proper temperature, proper humidity, the mosquito can survive for a protracted or a longer period of time, which means that the extrinsic incubation period can be increased, which means that this mosquito can bite multiple people and cause more disease. So when do we see the increase in dengue transmission is during the rainy seasons, because this is where after the summer, when all the water sources have dried and the eggs have dried, once the rainy season starts, the water collects in these places, and then the eggs get favorable conditions and they will hatch again. And then there is an optimal mean temperature between 15 to 30 degrees, but we have seen these mosquitoes active up to 37 to 39 degrees centigrade also. And then shorter extrinsic incubation periods would be good. So it could be less than 12 days in 30 degrees centigrade. So as and when the temperature goes up, the incubation period in the mosquito can come down, and then it can cause more disease. So we have already discussed why extrinsic incubation period is important, and why we need to study it. Coming to the clinical manifestations, we know that dengue has phases, 3 phases of the fever, and then you have a high fever along with symptoms of headache. There is retroorbital pain or pain behind the ears. Muscle and joint pains are there, which characterizes both dengue and chikungunya. There is nausea, vomiting, swollen glands, and rashes can be seen because of thrombocytopenia. Okay. So usually begin 4 days after the infection, and then last for anywhere between 2 to 7 to 14 days. Okay. And during the second infection, we can see severe types of dengue as well. So secondary dengue, or is the more severe type of dengue. Usually we say that anything that follows dengue type 2, or 4 following 2, or 3 following 1 are more severe. Okay. These are not very well established, but what is well established through various studies is that definitely the second time that a person gets dengue, there is antibody dependent enhancement, and that causes a more severe form of the disease. So during severe dengue, there will be abdominal pain, persistent vomiting, there will be changes in the breathing, there will be multiple bleeding episodes will be seen, because the platelets would go down, sometimes even less than 20 and 10,000 per cubic millimeter, the platelets would go down, right? There would also be hematemesis, we would see, and then there would be widespread rashes. And this is, although previously we used to discuss about tourniquet tests, we usually don't suggest tourniquet tests now. But then in severe dengue, even without the tourniquet, even with light pressure, you can see that there is a capillary dehiscence. So diagnosis of dengue, we do it in 2 types. We do direct method and indirect method. So direct method is where we directly try to find out if the virus is present in the body by using virus isolation, where we culture, or doing nucleic acid detection, where we run PCR, or antigen detection, which we can do by rapid diagnostic tests as well as ELISA. Indirect method would be where we would see the serology, that is immunoglobulin M and immunoglobulin G would be checked. Right. Along with this, we also have tourniquet test, but this is not suggested now. Right. So coming to the advantages of NS1 antigen, this is the most commonly used test in most of the public health setup. We have NS1 kit, we have a card test. You just put some amount of sample on it, and then you would see bands, which is basically the rapid diagnostic test that we have. Okay, but again, the limitation of NS1 antigen detection is that the test sensitivity varies by serotype. So we have seen that dengue type 4 has about only 49% sensitivity. And then in case of secondary infections, the pre-existing IgG shortens the window of NS1 antigen or NS1 protein. So the detection will reduce as well as the sensitivity will come down. Coming to the IgG, IgM antibody, this we have seen multiple times that the sensitivity and specificity are okay, but they are they're not up to the mark. They're not very easy to identify based on the just the immunoglobulins. And then there is a lot of cross reactivity that we see, especially dengue, IgG, IgM cross react with Zika, cross react with KFT virus. Most of the flaviviruses they do cross react, and this cross reaction will again mean that there is a major limitation in using these, and then sometimes we may not be able to detect even with the immunoglobulin ELISAs. So coming to co-infections, as I said, Zika and chickpea also present with similar symptoms as dengue, and we have reports where dengue and chickpea have been co-infected, but usually only one virus is the one that causes the disease, and sometimes we just find the other virus in the mosquito. This is not a study in the human population, but when we do xenomonitoring of mosquitoes, we've seen that the same mosquito can carry both the viruses, although how much of it can transmit is a question. So a similar onset of symptoms and similar type of complications can mean that diagnosis is very tricky. And again, given that the flaviviruses, so there will be some cross reactivity, especially if you're using IgG and IgM. So the better tests to detect them would be polymerase chain reaction, that is a PCR test for nucleic acid. But this is one both expensive as well as it takes a lot of time and a lot of expertise to run these tests. And coming to dengue, after first 3 days of fever, you may not always see the viral PCR coming back as positive. Along with this, we have once we have detected another thing, there are multiple vaccine candidates that are being explored because we already know that there is no treatment for dengue. We have management strategies for dengue, which most of us would be familiar with. We have household management of dengue for cases that are not very, very severe. So we would, especially because we don't want to overburden the public health system, what we do is any mild case or any case which has fever that is not extremely severe or no other complications, no vomiting, no hematemesis or abdominal pain or such. And if the platelet levels are uh, normal or over 50,000, we usually don't advise admission. We ask them to stay at home and consume a lot of water and then take just paracetamol. Try to avoid other NSAIDs and then stay at home and have a home care and then get regular check of their platelet counts to see how it is progressing. And once the fever breaks, then there is a lot of improvement that will be seen in the platelet counts. So this is what we aim for. And in severe cases, it is better to admit them. Usually, we suggest platelets less than 50,000. They require close watch, and they or less than 20,000 they require transfusion. But this is more of a guideline that was set up because of the public health scenario in the country, because we may not have enough blood in the blood bank to get fresh frozen plasma or platelet fragments to be given to patients, especially when the number of cases in the country are very high, right? So in a country like ours, where we have a large population that is both at risk and has been exposed to dengue, the most important aspect that we need to concentrate on would be the prevention of the disease. So, prevention of dengue, we will, of course, we can always structure it as primary, secondary, tertiary preventions and primary prevention and such. So, one of them would be vaccine, right? There are multiple studies that are going on, but the problem is the amount of immunogenicity that we see with the vaccine is also there. And the second thing is most of these vaccines require some type of adjuvants that will increase the effectiveness of the vaccine. And when it comes to adjuvants, there is a lot of control on the adjuvants in the market because large players like GlaxoSmithKline and uh, Moderna, and these companies, they control the flow of adjuvants in the market, right? So this is the reason why many public health vaccines, like vaccine for tuberculosis, vaccine for malaria, or vaccine for dengue, getting the adjuvant is a problem. And at the same time, given that it is a viral uh, it's a viral disease. There is a lot of structural changes that happen in Delhi. It undergoes a lot of structural changes year on year, and that also makes it difficult to have a very stable vaccine for it currently. So there is one vaccine that has so far been licensed, which is Dengvaxia, which is a live chimeric vaccine. It's a tetravalent vaccine for all the four strains, piggybacked on the yellow fever virus, right? But again, this vaccine is authorized only for 9 to 16-year-old children. And again, it is preferred in children who have previously been exposed to dengue. And therefore, it is a very, very limited application of this particular vaccine as well. So, what are the things that actually work is integrated vector management. This is something that we can follow in our houses, in and around our community, and we can all be vocal proponents for integrated vector management. So whenever we say integrated vector management, we usually think that, especially medical students, the answer is that integrated vector management is where you control the adult, the larvae, and the pupal stages of the insect, which is okay, this to an extent true, but it is not the whole truth, right? So in IVM, which is as a strategy was developed a few decades ago, but is only now being talked about with all the seriousness that it deserves, is because we always thought that there are other things that we can do to control, and only now we are realizing that IVM is the way to go forward because it has multiple components that are all working in sync, or that should all be working in sync rather. So we have environmental management methods where we have environmental modifications and environmental manipulations. These usually constitute the source reduction part. Okay. So if you're building houses, then you should build houses such a way that they're not easily, they don't collect water easily, and therefore they don't promote the growth of the uh, vectors, that is the mosquitoes. So this is also called engineering control. Okay? At the same time, if you have drains, then the drain should be closed. At the same time, if you have waste around the house, it should be collected and disposed of in the proper manner. And these are the mainstay of environmental management methods. And these give the maximum dividend if done properly. Along with this, we also always suggest personal protective measures. So, especially children and women or people who stay in and around the house during the biting time of the mosquitoes, they need to be specially mindful about the type of clothes that they wear, because dengue is one disease where using mosquito net may not be helpful because this mosquito is not very active in the night. This does not mean that the mosquito doesn't bite in the night. If it has to, it would. But then this mosquito does not roam around in the night. It prefers the daytime, right? And that would mean that there needs to be personal protection followed by people who are at risk of mosquito bites in the morning, in and around where the mosquitoes breed, which is in the urban settings, in the urban settings where there are a lot of people, which is around our houses. So that means wearing full sleeved clothing, using mosquito repellents, using space sprays, all out and Mortein sprays, right? So these can be used, and also at the same time we can use mosquito nets on the all the entrance, ingress and egress points of the house, and so that this is both environmental manipulation, modification, as well as personal protective measures built into one in the houses which can be practiced. Along with this, we have adulticides and larvicides, which form a part of chemical control methods. So notice how personal protective measures, which reduce man-mosquito contact, also extends into the chemical methods where we use chemical methods to prevent man-mosquito contact or personal protection, right? So we can use adulticides like thermal fogging or ultra-low volume fogging or spraying. Do remember that fogging as a method may not be very, very useful in the community at least. It may give a perception that something is being done. So it's more of a political tool per se, if you want to speak about it. But then, just like how we see the fog, and then everyone goes and the first thing that they do is close the doors and windows of the house, right? You would have seen this if there is a fogging being done in your area. Definitely, people in your house would just close the doors and windows so that there's a lot of fog and it doesn't come inside the house. But the actual thing is the mosquitoes, the fogging is not done for the mosquitoes that are there outside in the environment, because these mosquitoes can also see the fog and they can fly away. This fogging is done for the mosquitoes that are inside your house. So you need to open your doors and windows and allow this fog to enter the house. Okay. When that doesn't happen, the whole point of fogging is failed. The same way we have various larvicides that we can use. This can be sprayed again in and around the house. Along with this, we have developed multiple methods. There are insect growth regulators which can be sprayed on the water. So the larvae that emerge, they when they get converted to pupa, and the adults that emerge will either not survive well or they would die. Along with this, we have biological control methods where we use Bacillus thuringiensis, which is a bacteria which secretes spores, and this bacteria infects the larvae and kills them. The same way, we have larvivorous fishes which can feed on these larvae. These are biological as well as biochemical control methods. Bacillus thuringiensis is now being spoken about in a big way, and it is being pushed by the government because it is both environmentally safe as compared to other larvicides and adulticides that we use, and it can be deployed in larger quantities, and it is more easily deployable. So you just get cakes or spores that you need to disperse in the feeding areas, and that will take care of it. But along with this, just these are the different methods. But along with this, integrated vector management also means that there is an intersectoral collaboration. So the Department of Urban Planning or your municipal corporations need to be involved in this. Health education needs to be a part of it. Now we are exploring school education as a strategy in IVM, where we try to teach school children how they can prevent the disease in-house, in and around their houses. Because what we have realized is to do something in a community setup will take a lot of manpower, but to do something smaller scale in and around the house, it would be much easier. And therefore, we are trying to involve the education department also into this. Along with this, we need to have stricter laws, more environmental friendly laws, healthy public policies need to be made so that we talk about not just dengue, but about various vector-borne diseases and how they can be controlled. This is what I was telling you about personal protective measures. But another thing that we usually say is in Pondicherry and in other places, we have started this Friday Dry Day. I know Dry Day would has a different connotation, but then when we say Friday Dry Day, what we expect is people go around their houses, and then wherever there is a collection of water, they just throw it out and try to dry it up. Okay, and maintain a dry surrounding. And once a week is more than sufficient, because if we study the life cycle of the mosquito, we know that once the egg hatches, it becomes a larvae, and then it goes through four stages of growth, that is four instars, and then it becomes a pupa. And after another 3 to 4 days, then it becomes an adult. And once it becomes an adult, it is airborne and therefore very difficult for us to manage. But when it is in the water, it is the most vulnerable stage of the mosquito, and therefore it is very easy to control them at this stage. Therefore, many efforts are focused here where we try to trap the mosquito to lay eggs in a different, set of a water source which we artificially create, so that most of the mosquitoes would lay the eggs there. And once they hatch and become larvae, these can be thrown out and then they can be killed. Right. So that way we advise everyone, even you, to go around your houses once a week, one day in a week, you choose whichever day that is, and then find out all the places where water has collected. Not just these artificial collections that you see here, there could be artificial collections if you have a garden, there could be large leaves that can trap the water. And these mosquitoes, they require somewhere between 5 to 10 ml of water is sufficient for the eggs to hatch and the larvae to grow, right? So even if a small plant has a leaf that has collected water, the mosquitoes can grow in that. Okay. So these are some things that we need to be aware about and try to prevent. So this is what I was talking to you about when we talk about management. When we talk about integrated vector management, we see that we need to have inputs from all the areas, including patient care, where when we are treating a patient of dengue, we don't just treat them as a clinical case, right? We treat them as a social case. So this person got dengue because there was a level of prevention that failed in and around this person's house, or maybe their school, or maybe their workplace, right? So they need to be educated. They need to be told what to look out for or what caused the disease. It would hardly take about 2 minutes of our time to e- educate the patients and tell them where the disease started or how they got the disease and how they can prevent it. And it can also be, this is the place, especially in patient care, I have seen a lot of success stories happening here, because when the person is uh, suffering from the fever, or when he's just recovered from the fever, the memory of this is very fresh in the patient, right? So when we tell them that their family members, their mothers or their parents or their children can suffer from a similar disease, equally painful, the impact is a lot more, and they will be your torchbearers in control of the disease. This is the same strategy that we use when we talk of, population control and such, where we advise that women who has just delivered should be given IUDs and such. So postpartum intrauterine. So the same strategy here also. Once they have gone through the uh, disease, or once they've gone through an event, if you tell them how it can be prevented, that will cause a lot of effective behavior change in the patients, which they will carry back to their home, and they will increase the dengue control in and around their houses. And once that happens, we can effectively control dengue. Okay. But there are other parts that we need to concentrate on then, which would be controlling the ecological factors and the climatic factors to ensure that the disease does not rear its head again. And that requires a lot more inputs from our side, which is where advocacy comes in, where we show the data to people, where we show them how climate change has impacted the disease, and how increasing temperatures and increasing or erratic rainfall has caused more disease over the subsequent years. And this has led to more expenses, both on the government side as well as on the private side. And that type of advocacy, especially by healthcare providers, will be most helpful in trying to engage the policymakers to ensure that they prepare healthy public policies which are mindful of the environmental as well as ecological impact, uh, which can also focus as determinants of disease and dengue. So, in conclusion, one of the main factors is speedy urbanization with improper infrastructure and planning, and drops in travels that we see can also facilitate. And also, we need to understand that these mosquitoes are very, very hardy insects. That is, they have a passion for survival. So, we have seen especially in countries like Africa or in the continents like Africa, rather, we have seen that mosquitoes from other countries have easily traveled. Okay. We are running a project in VCRC which looks at mobile mosquitoes, that is, mosquitoes which use human transportation modes. Okay, so the mosquitoes that fly in your flights or that travel in your trains or in your buses, which go from one place to another, and these mosquitoes may be entirely new in that ecosystem. This is how there is a specific species of mosquitoes, Anopheles stephensii, which is wreaking havoc in Africa because Africa, this species was naive in Africa, and especially it was an urban malaria vector, and it got adapted to the urban situation in India and other and in the Middle East, and then it has migrated to Africa through human modes of transport. And now, because it is a naive area, it is wreaking havoc there. The same way, there could be multiple other things that can impact the outcome of dengue in the future. And this is why we need to band together as one and concentrate on integrated vector management as the strategy for controlling dengue and other vector-borne diseases. Because the same IVM, without any extra steps, can be used for almost all the mosquito-borne diseases. And that is a great step going forward. Thank you.
Thank you, Doctor. That was a really wonderful, very eye-opening session with a lot of inputs which you have shared, especially the practical aspects which you mentioned, how we can protect. That is really interesting, and especially I wanted to probe a little bit more on that ADE concept.
Yes.
Which you mentioned. So I will start off with that. And meanwhile, I request all the participants to check the chat box. There is a chat whatsapp.com kind of link. We request you to click that and join the group so that every week by Monday, Tuesday, you will receive the webinar alerts. Because last week I heard that some of you are not receiving regularly. Please join that. Meanwhile, as I thank our excellent speaker because the session was really very plain and simple as narrated. Vaccines are not going to come to the rescue, whereas our lifestyle modifications and environmental integrity, that is what is the key here. So I would like to ask Dr. Srikanth, can you just give us a little bit more on AD, doctor? Because as I understand from the presentation also, recently one of my clinical friend in my current workplace, she was suffering with, she's a doctor herself, she
Okay.
suffered with this particular episode of dengue, and it was concerning for us when she told us that the platelet count has come to less than 80,000, but remarkably she recovered and came back to work within a couple of days. But she was looking very haggard and tiresome after this experience. So as you correctly said, when someone in our family or in our contact goes through that, when we look at it as a first hand experience, it is more traumatic. And the kind of numbers you have given, like half the country is already exposed kind of thing. So can you please throw more light on ADE, doctor?
So, AD is a very simple thing to understand. Uh, Basically, whenever a virus enters the body tries to fight the virus. Right? So, there are multiple immunological steps that occur in a cascade, which will first identify the viron or the virus. And once it identifies, it signals to the other cells. And then we have B lymphocytes and others which come and attack this and then try to mount an immune response against the disease. But what happens is when there is a previously existing antibody, right? So in case of dengue, say you were infected with dengue type 2 or type 1 or so, and then after 3 months or within 3 months, you get exposed to a new virus, which has similar viron on the outside, but it's a different serotype. What happens is, as soon as the viron is detected, you have the antibodies that are present. So because these antibodies are present, they will attach to the Fc receptor regions, and then the body fails to recognize that there is a new infection or there is a severe infection, because it notices that the antibody is already there and the antibody is attached to something and it is working on it. So what happens is that these antibodies will block the subsequent endosomal fusion, and that would mean that the body fails to mount an adequate response. And by the time the body realizes that the viral growth is so high, and then it will start destroying the cells in which it is growing, and then it causes a cytokine storm, because all the cytokines from within the cell and the other places, they increase and it causes a storm, and this will lead to uh, more severe form of the disease. So this is what we say as antibody dependent enhancement.
Wonderful. Thank you so much for that detailed understanding. So, coming to another case of dengue in my workplace, this friend of mine, she is a non medical person, but she fits more into that second picture where you said there will be abdominal pain. She has that predominant. Today morning, also, I was talking to her, inquiring how she's doing from yesterday to today. She still says that she has that persistent abdominal pain, which is severe in nature, and also this joint pains which are very severe and excruciating. So this is the second case I'm encountering within 1 week in my workplace, one with a doctor and one with a non-medical colleague, both females.
Yeah. Actually, what I see here is we run a study on acute febrile illnesses. So we collaborate with 3 to 4 hospitals in Pondicherry, and any cases of fever which have not been detected by the regular tests that they have in the hospital, we collect it and we run PCR tests here for a panel of vector-borne diseases. So during this interaction, what I noticed is, of late, we're seeing a lot of dengue cases present, not just with abdominal pain, but also with loose stools.
Yes, diarrhea. She also had that. I wanted to add now. Yes. She
Many,
also had severe, as you said, the very first thing she told me was this only.
yeah. So the mechanism for this, there we have, studies that say probable mechanisms for this, but then established mechanism for this we are still exploring. But this has been a very recent development. Earlier, we used to have dengue with loose stools or abdominal pain, but this was not a lot of the quantity was lesser, but now it is more. So now we are trying to see if this could be because of maybe subsequent infections or infections that have already sensitized the immunoregulation regulators in the gut, and therefore subsequent infections are irritating these and then causing more secretions, or what is happening. That is something that we're trying to find out. But this is a new thing. So usually when we notice that there is a lot of diarrhea or so, we would say, okay, it might be viral diarrhea. We will just ask them, does it smell bad, or is it too watery, or is it sticky or such? But we would not think of doing a CBC, especially in an outpatient setting, because more often than not, patients are not very happy running multiple tests. So, and especially when cases of diarrhea comes in, we just take the diarrhea history and we say, okay, it might be viral diarrhea. You just have ORS and it should be fine. But then I think now it needs to become a practice where we teach students, as well as in our practice, whenever we see a case of viral diarrhea, we at least run a CBC to see if they have any, thrombocytopenia.
Okay. Thank you, doctor. So now I request the participants, if you have any questions related to our topic today, you can directly interact with our speaker. This is a great opportunity coming from a reputed premier institution in Pondicherry, which is focusing on vector Control and Research Center, we cannot get any better speaker than today's speaker to talk about this topic. So I request and invite all of you. I'm seeing Dr. Bala logged in, some very new participants. We welcome all of you. So you can just post some of your questions. Meanwhile, I'll try to continue this discussion with Dr. Srikanth. Dr. Srikanth, you said like you are working in this One Health unit, and from our couple of previous sessions, also the speakers impounded on us what is this One Health strategy, because I'm seeing a lot of new participants today other than our regular participants and patrons. So I request you to take a couple of minutes and briefly discuss what is this One Health approach when it comes to today's topic.
So, as I said, when we talk of health, it would be a lot of hubris on our part to think that health is only human health, right? Especially with COVID and now with Nipah and all these diseases, what we have noticed is the diseases that are occurring in the animals, right? Which we usually say sylvatic cycle and we try to forget it. But these diseases have the power or have the ability to impact humans and cause diseases in humans. So when we talk of pathogens, we say pathogens have species barriers. Okay, so this particular pathogen infects this particular species. It may not be adapted to humans or to any other species. But then the species barrier is not like a thick line. It's a very porous barrier. So when the environmental situation and also the animal and human situation, when they all intertwine and then this align properly, the pathogen can jump species barriers like we have seen in COVID-19. Uh, as long as we don't go into the conspiracy theories and such, even otherwise, when we discuss, it is a pathogen that exists in bat. Nipah is a pathogen that exists in bats. There are multiple other pathogens that exist in bats. We have pathogens that exist in birds, like Japanese encephalitis virus. We have pathogens that exist in pigs, again, Japanese encephalitis virus. We have swine flu. We have different avian flus. So, consistently, if we see, all of these diseases have an animal component in it, right? And when humans disregard or when health professionals disregard, because we tend to see diseases in a very unidirectional way. Patient comes to me, I run the test says this, I give the treatment, I send the patient back. But then where am I sending the patient back to? So I get a patient of dengue. I know the patient has dengue. I give him paracetamol or such, and then I send the patient back home to the same place where there is Aedes mosquito roaming around, which can bite him again and pick up the virus from him and then bite his family members or his neighbors or someone else, right? So we need to think in this parallel view. So when it comes to One Health, the idea is that any happenings in the environment, any happenings in the animal health has the ability to impact humans. And unless we work together with veterinarians, with ecologists, we will not be able to tackle the next COVID pandemic. So if we
Yes,
have to be ready for pandemic or pandemic preparedness, then
preparedness.
One Health is the way to go, where we keep an eye out. Just
Yes.
like how we have surveillance now for human diseases, the same IDSP is being used for animal disease surveillance. But again, everywhere, the one thing that we forget is the environmental health or how the climate or the climatological factors, how they shape the health. This is something that we keep forgetting. And next time we may not be as lucky as we were with COVID.
Very true. That is really the reality of our existence today, with so much of global climate crisis. We are coming face to face with it on a daily basis. Every month they are telling this is the hottest October, this is the hottest September, this is the hottest August, and on top of that we are getting flash floods, especially the New York episode, and now with Afghanistan earthquakes and a lot of these calamities falling on our doorstep every day across the world. As you correctly mentioned, our interactions with this animal universe is like a daily affair, and One Health going forward is the prudent strategy to implement the preventive as well as promotive aspects. Both of us coming from community medicine, we strongly believe in this community aspects. That is also the reason we are conducting these webinars, inviting variety of reputed scientists who are practicing it on a daily basis to come and talk to us, because that is where the message reaches out to public. Today we have 30 plus audience, and through them, as you said, Dr. Srikanth, it reaches to their family members also, because you said, like, if there is a case of suspected or confirmed dengue in a family, it means that other people are also at risk, or they might have been exposed to that similar mosquitoes and mosquito bites. So that is one excellent message going forward. We need to keep ourselves and our families, our neighborhoods, our communities safe, and also reminding all of us that Pondicherry Friday dry day, that is also one more concept. All of us can take a walk around our premises every Friday, as doctor has mentioned. Check out for any artificial collections of water in any kind of aperture or vessel or any discarded item, and try to empty that and dispose of that particular item if it is a waste collecting item, like coconut shells, tires, etc., etc., unused or used and thrown disposable water bottles, whatever. We need to be more mindful, as he mentioned very correctly. With that, I invite the last few comments or inputs from our mentors, Dr. Bala and Dr. Kanan. Final words, sir, because we are approaching 7 o'clock, and we want to relieve our speaker also. I'm thinking sir has taken enough time today.
Yeah, Dr. Srikanth, very, very informative. Yeah, you covered almost excellent way and very informative. So you have given everything in Excel to understand from the basic to uh, advanced level. So I have a question regarding prevention and control. That you told that biological control that is using baseless frequencies is effective. But I keep hearing this last more than 15 years, 20 years. Okay. So that it's a great larvacidal and all that. But where is the difficulties? Okay. So using this methodology and implementing it in our country.
Sir, there are many bottlenecks to this technology, particularly. This was one of the technologies from VCRC itself. And only very recently have we been able to push the government, again, policy and planning, to push the government to take it up in a big way. I think last year we transferred the technology to Hindustan Insecticides Limited, and now BTI has become the national standard. B17 strain is the Indian national standard by the Central Insecticide Board. They've made it as a national standard. And so all the other things will be evaluated against B17. But using of this particular B17 requires a push from the NVBDCP side or NCVBDC now, because the program has to take it up. B17 is not something that we can use it at home or household level. It is usually useful for larger water bodies or larger areas. So therefore, for that to happen, the NCVBDC has to take ownership of the uh, strain and start using it, which will slowly happen. It is only now it is moving in the correct direction, because as you know, so there is a lot of red tape, a lot of bureaucratic things that have to go one after the other, and until step 4 is not done, you cannot move forward and to step 5. And it's not like everything can happen in tandem. So getting that done itself, I think VCRC is a case study for that. For the last 30 years, although B17 was described in somewhere around 80s, 87, when it was shown that it works very well, It has taken over 30 years for it to come into the public space as a effective insecticide and to move forward from there. So it will take some time, but now things are moving a little faster when it comes to B17, because all these days everyone thought chemicals would be better, but coming to the environment point of view, chemicals are always a drawback.
Yes. A
Thank
lot of appreciation. Yes, sir, Dr. Bala.
Thank you. Very informative talk. I think that
Yes.
everybody would have enjoyed it.
Yes, very, very true, sir. Because I'm seeing the chat box, everyone is appreciating the session because we are very much concerned about the rise of dengue cases since last 2 weeks in our hospitals. That's why I was searching for a speaker to deliver the talk. No better person, no much experienced speaker than Dr. Srikanth for today. Thank you so much, Dr. Srikanth. And we look forward to, if at all, if your opportunity presents again, we'll reach out to you at another time, because the talk is simply mesmerizingly pleasant to hear, as well as very, very thought-provoking concepts have been instilled, very subtle and without burdening us too much. Thank you so much. And I would like to request all our participants, Kannan sir has posted a link in the chat box. Please do attend to that. Otherwise, I may have an announcement next week. We already have confirmed our next week's speaker, who is going to be an entrepreneur, which is a very exciting topic. So we welcome all of you for the next week webinar, Thursday again, same time. Please join us. We will share the flyer in the group. So we request all of you to join the WhatsApp group so that you don't miss out on anything. With that, I would like to thank our speaker once again on behalf of Kairos, Kinetic and Global Biomedical Research Foundation. Thank you for joining our efforts to speak science on a regular basis. With support of speakers like you, we are engaging our audience in the science communication. Thank you all for joining, and we will see you next week. Have a great evening. Thank you, Doctor.
Thank you.